we have this little title slide, so we'll bring that up. So when you have yours up and you're ready to go, and once you get yours up like this, if you just hit the F5 button, it goes right into full screen like that. So, so when you're ready, just kind of give a nod back there, and then we'll bring you up on the screen, because we're going to have this title slide up while you're, so they don't see all the work happening while you're getting ready.
Okay. Because this is a throwaway slide.
It's just your title slide.
It's a title slide.
Yeah.
So
All right, let me.
you can put that up when I'm going to say a couple of words before I go to my first slide.
Understood. But when you get this slide up,
Yes.
just kind of give us a heads up or look to us, and we will now switch live to you from what's up here. Okay.
Good morning, everyone.
Since the first speakers don't have slides, I'm going to leave you up like that, okay? And when you stand up, we'll bring you.
That's my chair, but I'll move up once I'm done. Once I introduce you, I'm going to move. I'm going to get up.
Well, I'm not talking about, am I talking before Jen or after Jen? After Jen.
After.
So let her, yeah. I think you're saying, Zach, should you come down there?
Yeah, he can move here after I. Yeah.
So Bill, you must be old friends with Paul Keckley. He works with me now at Deloitte. He runs our Center for Health Solutions.
I think we're ready to get started. Can you hear me? Is this microphone on? Great. Okay. I'm Susan Graham, and it's my great pleasure to welcome you all to this workshop. We've got a wonderful turnout, as you can see. We've got a fantastic group of people, and I want to encourage you to make an effort to meet as many of the people who are here as you can. Partly, we're here to set a research agenda for health and information technology, and in part, this is a mixer, so that you get to know colleagues who work in other fields who could actually inform the research that you're interested in doing. We lost a few people. You have an attendance list. Somebody has the flu. 2 people have ear infections. So even within our community, we have our work cut out for us. I'm going to just mention a few logistic things. All of our activities are going to be on this floor. The breakout rooms are on this floor, and we'll be coming back to this ballroom for all of our plenary sessions. We have internet connections on the whole floor. The username is HealthIT, all lowercase. The password is meeting, and you should see Park 55 _conference come up when you look for a wireless network. So that's all there for you. I'm not going to tell you a lot about what we're going to do during the 2 days because my colleagues are going to do that for me. So it's my pleasure to introduce Jeanette Wing, who I've known for many years. Jeanette is the President's Professor of Computer Science at Carnegie Mellon University. She's a former department head at Carnegie Mellon. She's now on leave at the National Science Foundation, where she's the Assistant Director of Computer and Information Science and Engineering. Her biography is in your packet, and you'll be able to see the many other wonderful things that she's done. So please welcome Jeanette.
So thank you very much. Good morning and welcome, and thank you very much for coming to San Francisco to participate in this very important and timely workshop. The stars are aligned. First, the science and engineering communities, from computer science and information technology to medical science and healthcare technology, have and continue to make astonishing advances that point to a future of smart healthcare. The momentum in scientific and public interest in better healthcare has heightened over the past decade, as witnessed through the numerous workshops and National Academies studies, from the 2000 Institute of Medicine report to ARRA is Human, Building a Safer Health System, to the most recent 2009 National Research Council study, Computational Technology for Effective Healthcare. The community call to arms is for multidisciplinary research that will radically transform the way in which computing methods, techniques, and technologies are applied to improve the quality, safety, accessibility, and effectiveness of healthcare services. Second, societal, economic, and political interests are aligned, or, given current debates in Congress, shall I just say, are aligning. Let me speak just for the new administration. On August 4th, 2009, the Office of Management and Budget and the Office of Science and Technology Policy put out a joint memo that articulates the administration's priorities, urging the federal research and development agencies to invest in these priorities. This memo mentions 4 practical challenges for our nation. One of the 4, among the economy, energy, and national security, is healthcare and information technology. Specifically for health IT, the memo says, quote, apply biomedical science and information technology to help Americans live longer, healthier lives while reducing healthcare costs, end quote. The memo also urges federal agencies to pursue transformational solutions to these challenges. The message is clear. We collectively have tremendous potential to transform healthcare now and for the future, exploiting today's information technology and advances in IT that we cannot even foresee. Moreover, no one discipline and no one agency can do this alone. To generate the transformation in healthcare we hope for, we must work together to break new ground and to create new solutions. So the time is right for all of you and your colleagues in your respective disciplines to come together and address the societal grand challenge. You, as participants in this workshop, are a diverse group. You come from a variety of disciplines, including computer information science, engineering, medical science, medical informatics, healthcare technology, social and behavioral sciences, and beyond. Similarly, the time is right for federal agencies to work together to support ambitious frontier research in health IT. This workshop is co-sponsored by 5 federal agencies: Agency for Healthcare Research and Quality, ARRA, the National Institute of Standards and Technology, NIST, the National Library of Medicine, NLM, the National Science Foundation, NSF, and the Office of the National Coordinator for Health Information Technology, ONC. There are representatives from NIST, NLM, NSF, and ONC here today. And from NSF, there are representatives from 3 different directorates: SIZE, of course, engineering, and the social, behavioral, and economic sciences. For this workshop, I would like all of us to take a broad view of health IT. While research in electronic health records is important, we also include, and I'm just going to name a few areas: healthcare enterprise systems, modeling them, monitoring them, and making them interoperate. For example, using computational methods and techniques for design, modeling, simulation, prediction, analysis, and evaluation. For example, in the context of patient diagnosis, monitoring, and treatment. Trustworthy healthcare, software and network systems designed for safety, security, privacy, and usability. in mind for the patient, for the physician, and for trusted third parties. Data-driven and information-driven healthcare. Data collection through distributed sensing and participatory sensing. Data analysis through statistical methods, data federation, data mining, and machine learning. Intelligent decision-making based on massive fine-grained data sets. Smart healthcare, anytime, anywhere, anyone healthcare through self-monitoring, real-time learning and adaptation of software systems. New software and device technologies to advance healthcare delivery and services, including telemedicine, robotic surgery and prosthetics, embedded medical devices, smart sensors and actuators. Standards and metrics for interoperability. And of course, human, social, and organizational factors, including financial and incentive models and understanding economic implications of new healthcare systems. These are just to name a few, and to inspire you to think creatively and broadly in the next 2 days. Given this backdrop, let me turn to the point of this workshop. First, as Susan said, you may not know each other today, but one goal of this workshop is to build an interdisciplinary community that can advance the field of health IT. I sincerely hope you will get to know each other before you leave here tomorrow. Please meet and connect with people outside of your discipline. If you're in healthcare, talk to people in IT and vice versa. If you're a researcher, talk to practitioners and vice versa. And what's so amazing to me, I'm speaking off script now, what's so amazing to me is that I see a lot of fellow computer scientists who are coming from different areas of computing who I would not have realized have a shared interest in health IT. So I must imagine the same must be true of the medical profession as well. So in the next 2 days, keep an open mind, listen and learn each other's languages, respect and appreciate each other's cultures and perspectives. What will you do over the next 2 days? We, as organizers of this workshop, have 3 goals. First, to identify a rich collection of research challenges and opportunities in health IT and suggest promising new directions. The agencies want to hear from you, the community. Be bold and visionary in your thinking. Second, to grow an interdisciplinary community, to collaborate in defining the research goals and actually conducting the research. So we're providing this forum, this opportunity for you to meet people you never would have met before. And I'm hoping you do make new friends and new potential collaborators. Third, to identify a range of model, proof of concept, integrative systems that would serve as motivating and unifying forces to drive fundamental research and accelerate the transition of research outcomes into products and services. So let me just close with a few thanks. I would like to thank the people who have worked behind the scenes to make this workshop happen. The co-chairs Sue Graham and Zak Kahone, the organizing committee, I'm not going to name all of your names, but thank you very much for helping. The Computing Community Consortium and the Computing Research Association staff, the American Medical Informatics Association, Microsoft Research, and finally, SIZE's team, specifically Susie Iacono, Deb Crawford, and our AAAS fellow, Erwin Gianchandani. I even asked him right before this, how do you say your name? So on behalf of all the representatives from ARC, NIST, NLM, NSF, and ONC, I wish everyone a great workshop, and I hope to meet all of you. Thank you very much. Shall I just leave this here? Okay. Oh, well, someone's going to set up, right?
Thank you very much, Jeanette. I'd like to add to the thanks that Jeanette just offered thanks to 3 more people. Those are the people who did the local arrangements for us. Sally Alcala, Barbara Friel, Kathleen Carpenter. Kathleen is the one who you saw at the desk. The other 2 did a lot of the advanced work, without which we wouldn't all be here, so thanks to them as well. I'd also like to thank in advance our next speaker. Keith Strayer is the principal with the Health Sciences and Government Practice at Deloitte and Touche. And in addition to being a participant over the next 2 days, he has helped enormously in organizing this workshop. He is serving as a facilitator throughout the 2 days. He has a lot of experience in workshop organization, and it's my great pleasure to introduce him to you now.
Good morning, everyone. Okay, I just got a few minutes to make sure to go review process. If some of you got this paper in your, well, I think we mailed it to them, right? So you got this before the conference, and maybe you have it again in front of you. A couple of notes. So we do have work to do the next 2 days. It's not just fun and games. We have these breakout sessions that are basically 75 minutes under the best case scenario, right? 10:10 to 11:25 this morning. Here's what we'd like you to do. We'd like you to listen first, but when we get down to the breakout, it's very important that we go to work. In those 75 minutes, the first 30 minutes, well, 20 to 30 minutes, I would recommend that you focus on rapid ideation. The key output from that first part of the session is volume of ideas. Don't focus so much on the quality. Don't judge each other. Let's not provide too much feedback right off the bat. Let's just kind of let it come right out. Do a rapid ideation, let it flow out, capture the ideas, and you can ask someone to serve as the moderator of the group and the scribe of the group. But the key there is not to actually pass judgment too early, but to really grab as many ideas as you can to fill the board with all the topics that came to mind in the context of a research problem. In the 20 to 30 minute range, so around 10:30, 10:40, I recommend you start willowing those down. Cluster them together. You know, you're going to probably see some common themes emerge. Some of them will overlap. Some of them will be similar enough that you maybe can combine them. And let's start getting them down to a group, because ultimately we're going to capture everything. All the ideas will be important, but for the purposes of the next 2 days, we want to take those ideas and we want to turn them into fully vetted research problem sets, which is described on the second page. You'll see the 4 boxes. And in order to get to this, the research problem, the approach, the challenges, risks, and the testbed approach, to get to the anatomy of this outcome, you're going to have to make some choices. You're going to have to select a couple. We can start with 50 ideas or 25 ideas or whatever your group, however prolific your group is, but ultimately you're going to have to pick 3. And what I recommend is you just, have a discussion amongst the group, have a vote, whatever works in that group, pick 3, and then spend the next 30 minutes, 10 minutes each, fully vetting out those ideas, and take that research problem and extend it through to those 4 boxes so you can end your breakout session with some real work done. If you get too caught up in debating the ideas, you'll get nothing done. And that's, so hopefully the dynamics of the group will tip towards productivity versus debate at the midway point. Work through those problems, and hopefully allocating about 10 minutes each. Try to fill those out. Again, don't be overly ambitious. If you read this example, it gives you a good sense of what we're looking for and how we want to distill it for today's purposes. And then the hard part, this is the really hard part. After about an hour, with 15 minutes left, you're going to have to pick 1. It's not the only one. It's not the most important one. It's not that everything else will get discarded. But for the purposes of today, we'd like every group to have the ability to present 1 idea at the end of the breakout sessions. Since there's 10 groups, we'll present 10 ideas. If you all presented all 3 of your best ideas, for example, that'd be 30, it'd become a little long. So we have about 30 minutes at the end of the breakout session. We'd like to give everyone a chance to have 2 to 3 minutes to come up and present their idea. And I think that'll be very helpful at the end of the first session, because it'll give you a sense of what everyone else is doing. And then obviously I think the next generation of ideas in the afternoon will even be a little bit more mature and sophisticated based on hearing the feedback from the group. So we're not here to judge. We're not here to be overly detailed in what's a good idea or a bad idea. This is about just volume of ideas, getting people to really, the mixer component, getting people to share ideas, be interdisciplinary, and to be in the room together, and there'll be a lot of value to that. If I will be roaming, others will be around. If there's any questions, we'll make sure that we'll be there to help. But it's not an overly sophisticated task, but it's important, because we don't want to just have an hour and a half discussion. We actually want to end with some output that's concrete, that's written out, and that people, think we actually produce some results so that we can shape our health IT research agenda. Now, this will be the format for today and tomorrow. Today and this afternoon, we'll do the same format, the same 75-minute breakout session. And then in the morning, we're going to do it a little bit differently, and we'll review that. Yeah, so there's a brainstorming board. Where's that fit?
It's going to be right over there.
So right outside in the main hallway.
On this wall.
Oh, I'm sorry, this wall.
This wall.
You can't see it, but use your imagination. That's going to be the brainstorming board. And basically, it's going to opportunity to post-it notes and put ideas on there. And that's going to grow over the course of the 2 days and become sort of a living document and a living way to capture the ideas. And I encourage you to come by and take a look at it during the course of the day and add to it. Don't take anything off, but put ideas on. And as we like to say in the facilitator world, shamelessly steal other people's ideas, because in the context of here, we're all sort of one collective genius, and that's a good thing. So that's the goal for the next day. Yes? See, I said the same thing. I'm glad you brought that up, because I had the same question this morning. Susan, maybe you can help me explain the assignments.
So what we've done today is we've picked a theme for the morning and a theme for the afternoon. I don't have them in front of me. The discussion this morning in your brainstorming phase will be focused around the different players, the perspective of the patient, the perspective of the caregiver, the perspective of public health. There's a fourth one. And that's just to get you started. The initial focus this afternoon will be about the process, keeping people healthy, diagnosing their problems, treating their problems, continuing care, and so on. And this is just a thought process. All of the ideas from the initial
I think his question was about that.
was about the breakouts?
Yeah.
I'm sorry, what
You have a list of people assigned a room.
Yeah, I think that's...
In some cases, you have group numbers, but these after.
Yeah, this is what's confusing people.
Page of legend, which has different.
Okay. There are multiple breakouts in some of the breakout rooms. And so when it says group 1 and group 2, that just means when you walk into the breakout room, there are going to be two tables.
Within the same physical room.
Labeled 1 and 2.
Okay. Yeah.
Yeah.
That's all
Yeah.
that is.
Yeah.
Yeah. We didn't have enough individual rooms for everybody, so
Yeah.
appreciate it. That's
And there'll be Post-its on those tables, and I encourage you to write down all of the ideas that you don't ultimately flesh out during the breakout, so that all the ideas get up on the brainstorming board, so that everybody can see them during the day and everybody can play with them and elaborate them.
And that's a very important point. To promote inclusiveness, capture your idea in a Post-it note and put it here if it didn't get fully vetted out in your table.
Right.
So nothing gets lost. And we'll capture all those ideas by the end of the session. All right? Is that good? Any other questions? Are we good?
The groups will change each time. In other words, you're in one group this morning, you'll be in a different group this afternoon,
And then a self-selection.
and then tomorrow morning, you'll have an opportunity to look at the brainstorming board, see the themes that are emerging, and put yourself in a group where you really feel you have a lot to say.
Okay, good. Great.
We're going to have a website. Everything we generate here is going to be on the website. The website that you've been looking at is going to go live sometime today, so that it's a community resource where we'll talk about this a little more Friday afternoon, whether we want a blog, how we want all of our continuing comments to be developed. But yes, it's all going to be available electronically.
Okay. So I have the distinct pleasure of now introducing my friend Zak. Does anyone here not know Zak? I mean, for the two people that don't know him, he spent the first 17 years of his life in Switzerland. I think this is his high school graduation picture on the front cover here. Well, I don't know. Do I need to introduce Zak? I mean, he's a great guy. He's the director of the Children's Hospital Informatics program, and and the Henderson Professor of Pediatrics and Science Technology at Harvard Medical School, and he's every 6 months he adds another role to his email signature, so it becomes quite complicated to scroll down. But he's a phenomenal guy and a great friend. I appreciate your asking me to be involved, and with that, I introduce Zak.
Thank you very much. So first of all, I would like to thank Keith Stryer for having volunteered his services. I just called and he agreed to, and I can think everybody agrees that he's been enormously helpful to this process, and I appreciate him volunteering his very precious time. So I just want, before I introduce the first of our two speakers, I just want to make a few points, which is when I was a graduate student, all too long ago, Keith Stryer, I was told by my thesis advisor that the knowledge representations and the decision support systems that we were building in the 1980s were soon going to be applied in medicine, and we just had to wait a little while for these electronic health record systems to be fully deployed, and we'd be all set to go. So that was in the 1980s. 20 to 30 years later, there's only a few places where that is currently true, and I think we have to ask ourselves why that is the case. And in contrast, we know that, for instance, in the case of the iPhone, there was essentially no iPhone applications 2 years ago. There's now 86,000 iPhone applications, several thousand of which are in the health IT space. I just saw a very nice one from one of our visitors here. And importantly, no one's paying them to use them, which is a little bit different from what we're seeing in healthcare IT. So I think that opportunity is huge here to think of how can we really do something different that breaks the mold. And I think you can only win by understanding how little is actually done in the healthcare system. Having said that, I would like to say that there is a cliche that you all well know: those who can't do, teach. And there's obviously truth behind that cliche, and therefore it's all the more remarkable that our two speakers today are the examples that defy the rule. Defy the rule. Defy, not define. Bill Stead is the Associate Vice Chancellor at the Vanderbilt University Medical Center, but he has truly done. He was involved in the very early exploitation of electronic healthcare data for linking cardiac outcomes to practice back in the 70s. He helped build one of the first truly functional electronic health record systems. He even practiced that medical discipline that's only second in complexity to endocrinology, that is nephrology, while becoming a clinical and research leader. But more importantly, he's taken what he did in the research realm and put it into practice so that Vanderbilt is one of the few examples of successful implementation of these practices. And he has also been a leader in showing us the way. I think we've been recalcitrant in following the lead, and it's my hope that with the report that I think he will summarize to you in his talk that was developed for the Institute of Medicine and National Academy of Sciences, we will now be in better position to follow his lead. So I'm going to ask Bill to give his presentation, and then after that I'll introduce Latanya Sweeney. So thank you very much, Bill.
Thank you, Zach. What I want, can you bring up my slide set? Thank you. What I want to do is to begin our work together by laying out why we need a new paradigm for healthcare IT. Because as Zach began to allude, we're not going to do what the administration wants unless we break the mold. And we need a new paradigm. And I believe that new paradigm poses significant research challenges that are worthy of the best of the collective disciplines that have been brought together at this session. I had the privilege in 2007 to 2008 of chairing an NRC committee that was to engage the computer science research community in healthcare informatics. And as a first step, what we did was try to assess the gap between the best of healthcare IT as deployed today and what would in fact be required to support a system of care that produced the results we want. The idea was simply to ask the question, is there a research problem here, or can we just deploy what we have and get what we want? The answer came out on Friday in January, a couple of days before Obama's statement about the commitment to healthcare IT. And basically we said that if we simply accelerate what we are doing today, we will not fix the system, and we may, in fact, make it worse. The key idea is that we need to provide information approaches that help people think about problems. We've got to deal with the cognitive aspects of biology and healthcare. And those cognitive aspects pose a number of grand research challenges at the intersection of the computational sciences, the social sciences, engineering, etc., that are each of a magnitude that sequencing the human genome was 20 years ago. Given that, the second point of the report was that as we deploy today's technology, we need to focus on measurable improvement, because success in using this technology to improve healthcare takes iterative adaptation of roles, process, and technology so the three work together. And doing that poses similarly large research challenges at the intersection of informatics, implementation science, health services research, etc. So there's a resounding yes out of this effort that there is a problem that we've got to come together in new ways to solve. The makeup of the committee shows the kind of diverse backgrounds that have to be brought together to think about this problem. People from medicine, biology, generalists such as myself, to people with deep aspects and deep expertise in different aspects of computer science or social science. The way the committee did its work was to take what the Institute of Medicine did almost 10 years ago in the Quality Chasm series in defining what we would want in a system of care that would produce results, a system that was safe, effective, patient-centered, timely, efficient, and equitable. And these are the information-intensive aspects of what it would take to support that vision. So the comprehensive data about patients across locales and time. Cognitive support that brings together the information about the patient with the best evidence in a way that lets you quickly focus on and making decisions. An information infrastructure that allows you to rapidly assimilate new technology. Anybody that lives in healthcare, but first, let's have a show of hands. Who lives in healthcare here? Which of you have IT infrastructure that actually meets the things on this list? Okay, that's the challenge. Now, once we understood the target, we then took this group and instead of putting them in a room, we put them into 8 of the systems that are leading the pack in some aspect of using IT to improve healthcare. You'll see these systems were a mixture of academic, rural, government-owned, for-profit, not-for-profit, places that have used commercial systems, places that have built their own. And this is what we saw. We saw a number of successes Remember, we're looking at places from amongst the best, but we saw many, many more challenges. So in the places that are doing the best, we're discovering that the records are increasingly fragmented. You would go on rounds and you would see 5 different members of the care team standing in a circle facing each other over computers on wheels, each looking at a different part of the record, all the integration taking place in conversation, nobody knowing whether they were looking at the most important things or not. The clinical interfaces, there was no consistency in how somebody went to find something. It was all individually known. Documentation after the fact. Would you like to fly on an airplane where the pilots and co-pilots take off and then fill out the checklist? That's what we do in healthcare with checklists, because we have not redefined our roles so that we have a pilot and a co-pilot where one can be working the checklist and where our culture actually permits them to stop the other. So these are the kind of problems. So as we looked at it, what we discovered was that these places, maybe the average hospital is 5 on a scale of 100, and these places were 15 or 20, 3-4 times better, not a few percent, 3 to 4 times better than the average. And yet the gap between 15 and 20 and 100 is so great that if we just do more of what we're doing there, we won't get there. It's like trying to go to the moon in a jet airplane. Got to be different. And take advantage of what we have. The shuttle's just a plane sitting on top of a rocket, but you're not trying to do it with just one or the other. You're actually putting these different technologies together. We got to figure that out. Now, the committee had a couple of eureka moments. And this depicts one of them as to what the fundamental problem is. If you look at other industries, they use a family of quite different computational techniques to solve problems. They use automation, where you've got a well-designed system that needs to be done over and over again. They use connectivity, things like social networking, just to connect people to each other and to systems. Data mining, just, discovering relationships amongst disparate sources. Decision support, statistically based decision support, not rule-based decision support. Now, on healthcare, almost 90% of what you see is automation. And we're trying to take something that's supposed to work in small, well-defined systems and use it in healthcare. What's about it is small and well-defined. So we're trying to take it up to a scale it's not designed to do. When we use these other techniques, we bolt them on to an automation core, so the automation core becomes the rate-limiting step of what you can do. So one idea was we needed to rebalance the portfolio to take advantage of these, informatics, computer science kind of techniques that handle, 10 times the complexity of this technique, and they do it at 1/10 the cost and in 1/10 the time. That was one of the ahas. The second aha was this idea about what it would really take to provide cognitive support. I was trained as a clinical nephrologist. Now, when I walked in to see a patient, I would have a model in my head of what was going on. And as new data came in, it would fit that model or it wouldn't. If it fit that model, I just remembered the model, not the new data. If it differed a little bit, I'd remember the model and a little bit different. If it differed a lot, I'd say, oops, I need to stop. Maybe I need 2 models. Maybe I need a different model. I'd rethink the problem. Healthcare IT doesn't work that way. It chains us down here dealing with transaction-level data, the orders, the results. And even the decision support it applies is applied at the level of the transactions. What we want to do is get up above that, work at a much less specific level with a model of what is going on with the patient that lets us see the context of any new data that is coming in so that we can really understand how it fits in instead of having to do that in our own head. We want to then be able to drill down in this detail. Second, we really want to relate the data that is coming out of the research enterprise, this other side, with the work we're doing in the clinical enterprise if we're going to, in fact, have a rapidly changing learning system. There's almost none of that connection today. And you think about it, what we need is the same kind of buildup as we have on the clinical side. We need the systems to support protocol, raw biological observations. Those then will result in generalizable knowledge, which then can be turned into general medical logic, if you will, which then can be instantiated as patient-specific decision support. Each of these are fundamentally different problems. If we were to succeed in deploying everything we have today, we would have solved 2/8 of the problem. We would have gotten this blue circle deployed everywhere. So it's not that it's not important, but it's not enough. So just think what I would imagine a world. The report has a number of vignettes. Imagine a primary care provider working with a patient with heart disease. And they're actually sitting there working with a visual overlay that's animated of a model of the patient's heart built from their own imaging data over time. They can actually see the model run, informed by all of the data about that patient over time. They can see it at different time scales, so they can look at rest and exercise, or they can see how structure and function are changing over time, and they can drill down to look at something. Imagine how that would remove the cognitive burden of dealing with complexity. This is why it is urgent. This is a cartoon that Dan Macy's and I constructed a couple of years ago to lay out the magnitude of the problem. This black line at the bottom, 5 facts, is basically the number of facts this computer can juggle in a single decision. That number has not changed since cognitive research in the early 30s. It's not getting any better. Now, this is, the order of magnitude of the number of facts that are going to have to be handled in a decision as we move forward. It's reasonable to assume that we're going to be dealing with, trying to correlate 10 facts when we've simply got the benefits of structural genomics alone. It's reasonable to believe you have an order of magnitude increase as you add the functional piece with RNA, and then another order of magnitude as you add the effector mechanism of protein. And I saw a version of this slide that somebody's now modified that puts another order of magnitude for imaging. And I think the thing is, think about how fast this is going to happen. When we drew this slide 2 years ago, we thought that by 2014 you would have relevant relevant sequencing on a person, for the price of a whole body CT by 2014. That's now 2009 to 2012. The line is moving forward. So just imagine a doctor in a 15-minute encounter trying to deal with this. So I can tell you, for those of you that do not think the health system will change, it is going to implode. It does not matter, even if we didn't have quality problems, cost problems, and access problems, this would make it implode. So we've got to figure out how to solve the problem. Now, one of the ideas that has sort of emerged in the work since the report, really, is that we need to rethink our paradigm of interoperable information if we're going to do that. And one of the things that came out of a working group on standards at the National Library of Medicine in January was let's define interoperable data as data that can be aggregated and interpreted correctly in the light of today's knowledge and reinterpreted correctly as knowledge changes. Totally different model than trying to get a single vision of truth that is true for all time. You know, in the 70s, there were 2 types of diabetes. You know, in the 90s, there were 4. Now there are more than 20, and they're not, I mean, it's not like you're just getting more and more subdivisions. They overlap in ways that make recording what was known in the 70s just in that summary form useless today. You actually had to have all the raw understandings that underpin it. We've really got to separate our data from our systems that automate places. We've got to manage our data by itself. And is a second idea. And the third is, you know, yes, there are places where we can have standard data. I believe drug ingredients is an example, but they are quite limited. There are places where definitions are stable. And let's limit the standards to that, standard definition to that. This is a table of what such a new paradigm might look like, and I won't walk obviously through the detail, but the heart begins to get at this idea that instead of trying to have one record, we're actually talking about having, you know, easy access to all the sets of information that are about a patient. And you know, we want to be able to you know, statistically create robust answers about what truth may be. So we want to bring together different signals. Like when I was growing up and we'd get the chemical measurement for the potassium, we'd have a peak, we'd look at the peak T wave and the heart. If those 2 things matched, we'd say it's probably right, because they're 2 quite different measures of something that correlates with potassium. Neither of them are actually measures of potassium. If you take that kind of model, you then could be balancing your use of these computational techniques quite differently, where you'd start by sort of saying that the challenge of creating the electronic health record is not to automate all of healthcare, it's just to aggregate all the information. So put simply, I believe that secure Google is a better model for what we're really thinking about in health records that will handle geography and time than, you know, our enterprise resource systems such as SAP, Oracle, PeopleSoft, et cetera, which are automation kind of tools. Similarly, disease management dashboards, just you know, algorithms that let us calculate the what appears to be going on with the patient. Then you know, evidence-based advisors, you know, simple portal-based kind of work lists, break the problem up and match the computational technique to the problem. So with that kind of idea of a paradigm shift, what are some of the grand research challenges that emerged in the study report? The first was this idea of cognitive support, and I won't go into that more. The second is that if you're actually going to provide that kind of cognitive support, we're going to have very robust modeling capabilities. In essence, we're going to have to model you know, each of the subsystems. Those models are going to have to be able to handle time scale ranging from, you know, very sub-second to hours for something like digestion to years for some things like your bone system. They're also going to have to handle different biologic scales, from, you know, the molecular subsystems to the way things come together in organs to populations. We need to be able to parameterize those models from clinical data, so we individualize them to the patient. We need to be able to show the linkage amongst those models. We need new computational platforms that will actually allow those different components to operate in parallel in a way that will actually let us see a hierarchical simulation where each of the components is you know, related but actually operating separately. Very different from any kind of modeling that we have today. Automation, you know, what are the techniques that would allow us to put together systems that have been developed differently, but put them together so that you can trust the way that they work together. Data sharing, how do we do incremental data integration so that we can constantly bring in the new things without having to actually go back and rebuild the base models? Data management at scale involves things like, how do we do machine-assisted annotation in a machine-readable way? How do we mine information from text and images? And then this idea of automated full capture of physician-patient interactions. This idea that we're going to get computer technology that is so good that it lets a doctor or another care provider record everything in the middle of an encounter is just crazy. The doctor shouldn't be recording anything but what they sense. They are, in fact, a sensing device, and what they decide or what they think. Those are the two things doctors should be recording. They shouldn't be recording what they do. Lord knows they shouldn't be recording what the patient says. How do we actually get self-documenting environments where all the pieces sort of get that information together, and all the user interface is around how we annotate and give high-level decision-making to what we're doing? So at that point, I'm about out of my time window. I hope that you can detect that I believe this problem, we not only have a problem of alignment, I think we have a problem of urgency. As I look around you, this room, there are very few people here. In fact, I don't think I see a one that can count on not needing health care before the current system implodes. So this is about you. And I hope that that we will collectively figure out how to tackle these really, truly grand challenges. Thank you.
Yes, thank you, Bill, for delivering as I knew you would. Reminds me, your comments remind me that I saw on one of the direct-to-consumer genomics companies on their website, in which they reflect back to you your genome-wide results on 500,000 single nucleotide polymorphisms, the following recommendation. They said, and if you want more detail, we recommend that you discuss the results with your primary care practitioner. And I couldn't figure out which was more amusing, the fact that they thought the primary care practitioner could actually help with the interpretation, or that they believed that the primary care practitioner would have, as they pointed out on the website, 90 minutes for this discussion. Having said that, let's go back to more individuals who defy the rule of those who can't do teach. So I've known Latanya for quite a while, ever since she was a graduate student, and as a graduate student, she was as formidable as she is today, and as much as of a clear leader and clear teacher as she is today. So for example, she was able to really highlight how vulnerable we were in terms of disclosure, for example, by showing that merely seeing then Governor Weld vomit publicly on television, and then having access to state insurance records would allow you to identify the unique individual of his age who met criteria. But then, unlike some privacy advocates, she did not merely say, in fact, did not say the sky was falling. Instead, she went and did the thing that you'd expect of any constructive engineer and computer scientist, to go on and describe various methods of safely providing analyses of clinical data, of genomic data, which do not create unnecessary disclosures while allowing us to be an effective researcher. She's now a distinguished professor of computer science at Carnegie Mellon University, and has a leadership role at the Office of National Coordinator, and is a friend to many of us, and I want to thank her very much for coming to speak with us. And Latanya Sweeney.
Yeah, I have to tell you, I'm actually having an existential moment. This is not in my lifetime did I believe that the people that who actually, in my life, medical informatics and computer science have been distinct and separate entities. And work that I do in one, and the people that I know in one, I've never known the other one to even be in the same room. And so the fact that Zak and Bill, people who really started me into the whole world of privacy by having these incredible problems to work on, could be at the same event, that Jeanette Wing could be, someone I know later through computer science, is kind of an amazing thing. So I really hope that we'll be able to bring these communities together so that you'll all have the same existential moment. Say no, no, no. Yeah, no. Thanks. Okay, thank you. So, you know, the previous speaker, Zak, mentioned interoperability, and William, Stead, or Bill talked a lot about clinical decision-making. I think, you know, if I think about healthcare sort of in general, it's like having a huge beast in a room that's totally dark. And all you've got is a little flashlight, a little pin light. And you get to see one part of the problem, not all of it. But it's a beast, it's a full system. And in order to make a change in it, you have to understand not just the limited view you have, but also all of the subsystems within that beast. And that makes it very difficult. And so Bill really shed light a lot from the viewpoint of clinical decision-making. I'm going to give you another flashlight point. There are a lot of other points as well. But Zak did hit one nerve that falls through all of them, and that's interoperability. The idea of how do I make these things work across these platforms. So last month, in public testimony in DC, I launched what's called the Advanced HIT Project. And this is a project whose job it is to sort of produce these visionary papers, working with stakeholders across all kinds of disciplines and do in-depth analysis. And our goal is to do the things that promote innovation in HIT. And so I'm really glad to be here from that vantage point. Advanced HIT is taking advantage of the fact that I'm currently located at Carnegie, Mellon, MIT, and Harvard. So we've been able to leverage people across all three campuses. So I have to start with this disclaimer that basically says anything I say or do is just my own opinion, and that in fact I may change my mind. That is not the opinion of the Obama administration, HHS, or ONC. For many of you may know, I was appointed to the Federal HIT Policy Committee, and so that's why the disclaimer. For those of you who don't know who that is, don't worry about it. So what do I want to talk to you about? The goal of this talk is basically saying there are lots of designs for a national health information infrastructure. That's the pin light that I'm going to use for this talk. And the question is, what are the research problems that are available for IT and computer scientists in particular? How might you be able to leverage in on this? And this week we had another public session, and another paper, the first paper from Advanced HIT was provided. And so in fact we're going to have copies of it. It'll be available later today. So it's not so much whether or not you agree with the perspective in the paper, but the front part of the paper, I think if you're not in this space, is really good at helping you understand what the terms are, the issues are, and things like that. So look for that later on today. So what do I mean by a national health information infrastructure? Well, basically, the idea, the vision of a national health information infrastructure is really simple. I want health information to flow seamlessly across handheld devices, devices in my home, to and from my provider, across labs. If I have a problem in another state, so here I am visiting California, if I had to go to the emergency room and I was unconscious, to what extent would they know about my medications, allergies, and so forth, a problem that I know many of you in medical informatics knows very well. But think about it, you knew that problem in the 1990s and we're still here, we can't do that. That's a pretty amazing issue. So the vision is that I should be able to go to an emergency room here, be unconscious, and that kind of information follow me. And that's all nice and good. And so people who've had that vision over the last 12 years began what I call the bottom-up approach. That is, they acquired money and opportunity and built regional exchanges, places where within a community like Indianapolis is a good example, where if I was in Indianapolis and I was a resident of Indianapolis and I went to a different hospital in the emergency room, they pretty much would know my medications, allergies, and so forth. But if I come from San Francisco and I go to the emergency room in Indiana, all bets are off. So the problem with the bottom-up approach, as you can imagine, is pretty spotted, and not many people have as many bonus points as Indianapolis does. But we had ARRA and to support the vision, the big vision. And ARRA is the stimulus bill, is more popularly known as the stimulus bill. And it has $18 billion to say, well, if we poured that kind of money, could you build an economic structure that would begin to help the vision come alive? And the problem that I want to talk to you about today is sort of what Bill said. If I just put more money into what we're doing and accelerate what we're doing, we don't get there. And so this is a serious problem for ONC and HHS, who basically has to solve this problem quickly, at least in the vision of the health information infrastructure. So I want to talk about those problems, not the short ones that ONC has to deal with, but the longer-term issues of what the research problems and what having a platform like that would mean and the innovation opportunities that come from that. So right away, tons of questions come up, and none of these questions do we have answers to for the national information infrastructure, by the way. But that's beside the point. There have been some designs. One design that's talked about in the paper is to leverage the medical billing framework. So that actually does answer, it has its own set of answers to a lot of those questions, and many of us believe that it might be a nice backbone against those bottom-up approaches. One of the things you see here, though, I'm not going to get into it, the paper does, though, is how I go to the doctor or even to a dentist, and this whole process has to happen in order to get paid. And that's kind of an amazing thing, but yet I can't find the opportunity to get my medications and allergies to my doctor if I show up in an emergency room. So we talk about how to convert that system, which processes billions of claims a year, how to leverage on that lightweight clinical information, so with minimal change. So that's one idea. And then there are other ideas. So we talked about so what you see in that upper left corner is the patient is at the provider facility. And so one other way to capture information is to take that information and put it in these regional exchanges, which I talked about as the bottom-up approach. And of course, many of us are aware of another way that's coming onto the scene, patient health records. Google Health, Dossier, there are many of them. And the idea that the patient should be the center of their own information. And therefore, if I go to the doctor, all they really have to do is find my access to my patient health record. So, so there are other flows. So that's what's meant by national health information infrastructure. So what are the ongoing opportunities for innovation and the ongoing issues for research problems? So I said, I gave myself the opportunity to define 3 of them. The first one I would call data consolidation or summary. And they answer some of the questions from the list that we saw earlier. And it's basically, and it was alluded to in the other talk, in Bill's talk as well, that there's just so much information. If I collect everything, there's so much information. Exactly how do I present exactly the knowledge, exactly the information that the provider needs then and there in a coherent way that they can actually make a decision. And that problem has lots of dimensions. First of all, a single encounter from a payment issue can have tons of bills, tons of transactions recorded. A single visit in intensive care generates tons and tons of data from each instrument. And so how do you figure out what's the best way? And that view changes based on the particular situation of the patient and the provider. And so that's an area of ongoing issues. And then some of the data may have privacy constraints. That is, if a woman had an abortion, should that knowledge be known to when she goes to see a pediatrist, for example? So it's not, it's very contextually based. And so we don't really know how to do that. We don't know how to do that well at all. Another area, which from an economic analysis area, so if you have to invest in something, I would invest in analytics, the secondary use of health data. There's just so much health data available. Even if ONC doesn't get this information infrastructure right, this will still be there, and that will be analytics and the use of secondary uses. There's so many reasons to drive it. You could talk about fraud detection. You can talk about, can I predict someone? I look at the historical data. Can I predict that that person is going to get a heart attack, and can I have an intervention against them? What are the key characteristics? That person had a heart attack. to what extent can I do some management with that person to change their life in a way that would stop them, because otherwise I know they're the kind that's going to have a second or a third. And those answers aren't trivial. I mean, if you actually try to solve this problem, and you've actually looked at a lot of this data, so I did a study with Blue Shield, California, a multi-year study. It's not easy. It's not easy to predict a person's outcome in the absence of intervention. Anyway, there are many things like that, and that's a huge open area that brings up a lot of issues. It certainly isn't a case of just what we know how to do in data mining, for example. Some of the reasons is that health data is extremely rich and extremely complicated, and we don't actually have good data mining algorithms that can deal with that kind of complexity in the data. Another issue is that the semantic models that go with the data has to play a role in the data mining algorithm. And we don't have data mining algorithms for which that works very well. So this is an open area that I think really resonates with movement that's happening in the data mining community anyway. Okay, then there's privacy, confidentiality, and liability. It's all the stakeholder barriers that can cause everything to come to a halting stop. And in the list of questions of things we didn't know how to do but had to perform in order to have a national infrastructure, you can see that it represented a lot more of the questions. And so to what extent can we actually develop tools in this kind of setting, this very robust setting, that would allow us to share the data somewhat freely or answer questions from the data somewhat easily with some guarantees of privacy or of confidentiality and also of liability. So one of the things that happens in the national information infrastructure, well, frankly, it's happened all across the board, is that privacy is usually a smokescreen for something else, some other issue. And so here I'm trying to finesse them out to say, you know, there are confidentiality issues around the provider or the people, the number of people an insurance company has and things like that that have to be taken into account. So those kinds of things can't really appear in the data. That is, I want you to learn certain inferences and I want to make sure you can't learn other inferences. And that's a particularly difficult thing to do. So so those are the three big areas that I was trying to just sort of splatter up there as places from my vantage point with my little flashlight in the HIT infrastructure space of where I could see some great innovation, some that's independent of any, and those are independent of whatever the final design might be. Let me just say a little bit about, some of you are looking, well, what does that have to do with privacy? And the reason they do that is, for those of you who don't know me, is because for the last 6 years, I ran the data privacy lab at Carnegie Mellon. And we worked on all kinds of data with all kinds of things. So I just want to give you a very quick litany of that experience. And then I want to tell you, the reason for doing that is to tell you what were the lessons learned as to why it is advanced HIT is the next step for us. So we work with lots of data. One of the big lessons we learned right away is that we were very good at changing the conversation. Often when a privacy problem would come up, it was an or. You either got the data or in order to get the data, you had to give up privacy. In order to have privacy, you couldn't use the data. And we were very good at finding sweet spots in all of these, where sort of the blue area denotes that, where you could have privacy and utility. So that was one thing that we learned. And we did all kinds of projects. I'm not going to take the time to walk through all of these, from anonymous data to web searching to finding people on the web, surveillance systems, de-identifying video in real time, DNA, social security numbers, identity angel, and so, and more recently, the work we did with the Department of Justice, that you wave high and we take a high resolution camera and get your fingerprints. The point is that we had an opportunity to work across lots of areas of computer science, planting seeds and looking at the technology that was causing privacy problems and be able to offer an initial solution. And we've also worked on the societal side. And what I can now say from that vantage point is that privacy problems can't be solved on the outside. That is, that they have to be done from the inside. The people who develop the technology are the people who have to solve the privacy problem. And any idea that you're going to add policy on later or you're going to add on a piece of technology later is usually not effective. It certainly often tends to be the less attractive solution. So it's much more important as you guys are moving forward in your research, even if you didn't start out doing privacy, You need to think about what might be the privacy implication and build in a few simple controls at that level. And because that's the only real way to make sure that you won't have a problem later. Okay, and that's what led us to Advance HIT. The beautiful thing about this ONC and the vision of the National Health Information Infrastructure is that, as Jeanette pointed out, all the stars are aligned. The policy, the money, the vision is all aligned, and also the opportunity to design this infrastructure is alive for us. And so the idea is to move forward with privacy protections embedded within that design. So from a technology policy standpoint, for me, this is a very exciting opportunity. And that's why we have the Advanced HIT project. Thank you.
Looking at Susan, if I'm not incorrect, we're actually slightly ahead of schedule. Would there be time for questions? Yes. George, Ripsack, Columbia.
Sure. Thank you. George Ripsack, Columbia University. Question for Bill. First of all, Bill, thank you for the report. It's wonderful. And thank you for pointing out the role of National Library of Medicine and also NSF and ARC to agree on EHR research. We have ARRA, $19 billion for implementation, $20 million potentially for EHR research. I think a 1,000 to 1 ratio is going too far, and we need to do something. And you know, this meeting is part of, I hope, drives this to something bigger than just the 20 million. My question, the vision that you presented is largely about building a better computer to work with the doctor. And I'm not yet convinced that that's the big breakthrough over the next 20 years. And is it building a system, whatever, partly computer, whatever, that brings people together, and it's more expertise sharing than a better computer that will change things the most. And I know it's fun to look at, say, warfarin and say if you have the genotype you can dose a little better, but what's going to change the health of the public is stopping everyone from smoking. And is that going to be solved more with a better computer or sharing expertise, patients, families? But we have the expert in the medical center. In our medical center, we have the world expert in this area. Then we have 1,000 doctors practicing substandard medicine, even though the person who knows the answer to that is sitting right upstairs from them at that instant. And I wondered to what degree it's really about sharing that expertise. We have a 30-year history of sending alerts to people. We've known how to do it. It hasn't taken off for some reason. Maybe what we need is to have that doctor feel like there's a person behind that alert that kind of triggers you socially into following the advice. We know it's good advice, but they ignore it. You know, so is it more social interaction and expertise sharing than a better computer?
You know, George, I think you know that I believe that that what we have to have is change in roles, change in process, and change in the technology. So if I came across sounding like a better computer would solve the problem, I didn't mean to do that. What I'm trying to describe is a level of complexity that cannot be dealt with by either individuals or healthcare providers without getting to a systems approach to how we work out choices. And you know, I believe that if we had the right kind of models, and if in schools kids were playing with games that were games, but that showed them the long-term effect of their current behavior, some of them would change. It's part of the solution. And so this is, I like Latanya's example of the connection of the different things we do in the science world and the things we've got to do in the societal world and how these all hook together. I mean, she's dead on, and she may want to comment. But.
Any other questions? Yes. While our question is coming up, I'd like to just see the audience with the following question that you might ask. George just asked, should we be building a better computer? And let me specifically ask, should we be building a better doctor? And how can we use information technology to get the right kind of information-seeking behavior and just-in-time use of these resources that address that huge rise in information or perhaps knowledge that Bill was alluding to. So, yes.
Hi, I'm Katie Seek from the University of Colorado at Boulder. I've been having some conversations with NHS Scotland about their health IT and empowering people to kind of reflect on their own health since they have a different healthcare setting. What are we trying to learn from a global sense? Like we're trying to look at our healthcare system differently. What are we learning from the rest of the world who have these kind of interoperable, semi-interoperable systems?
Well, I can't answer it from the provider clinical decision-making side, but from the national information side. What I've learned is if I look at the system from England, where they have a very different system of payment in the sense of there's only one payer, and the data that gets collected. The data drives policy decision-making, as you would expect. It drives healthcare decisions and public health decisions, as you would expect. But also it gives them a kind of bias. A good example of that has been disease management. So at some point in their history, they decided, for example, to build bigger hospitals. But what they really needed were people who could, nurses or whoever, would go into the home and try to change the environment in the home, so sort of disease management at that level. They don't have a mechanism to do that because they put the money in the hospitals. So there's this funny kind of bias. We, on the other hand, whether we like it or don't like it or think it's been effective or not is still a debatable issue, but disease management programs certainly in the United States look a heck of a lot better than the ones that we've seen in England in comparison. And that's because the people who you pay are trying to have an incentive, i.e. your insurance company, to try to change that. That's also bad. So, but I use that example, not that insurance companies should make these decisions. I don't mean that. What I'm using the example is how we design the national infrastructure will determine the kinds of problems that we're likely to see and will determine the kinds of problems, the kind of solutions we're likely to propose. So it's extremely important that you get it right. Now, the ONC model under the current stimulus bill does address a lot of quality measures. They're called CMS quality measures, that once the data is provided, they want to be able to, they want reports from CMS about the national state of people's health care on various dimensions. It's over 100 of them. So it's not a trivial.
Bill?
There are examples all around the world of individual things that are done better in one system or another. However, none of the systems are providing, it's like looking at the hospitals that are 4 times better than the others, but 1/5 of what we need. None of them are anywhere close. So if you look at all of the causes of premature mortality, 10% of them are due to medical care shortfalls. If you add up the access problems, the medical errors, and everything else, it's 10%, I mean, the healthcare part, the medical care part, it's 10% of premature mortality. So the system as it is designed today is missing that other 90% almost completely. And so we've got to, I mean, it plays back into some of George's comments, plays back to Zak's comment about needing a better doctor. I mean, truth be known, we've got to make it so that the individual and their support community are the majority of the true health interaction that we're helping, and that frankly we're keeping them from needing the system. It's a complete flip of the model, and no place is anywhere close to that.
Right. But are we keeping an open dialogue with them so our systems, once we have it solved, can interact together? We're talking about interoperability among our own country, but like interoperability around the whole world. I know it's a
Well, there are things like, things like the effort to have the SNOMED license, which, started out as a national license to SNOMED. It's in essence now a global license. There are efforts to make these pieces
So
work
let me
together.
actually quickly give you an example. It was actually done by a non-MD, hugely impactful, used by the CDC and WHO and many other organizations. And again, not done by MD and totally relies on non-traditional medical sources, and that's healthmap.org. Healthmap.org goes and buries itself into Google News, into mailing lists of infectious disease outbreaks, and through natural language processing, extracts what disease is happening where. And that's at the global level. There was no World Health smart body that did that for us. It was just a bunch of smart girls and boys using fairly straightforward computer science techniques to actually aggregate. Parvati.
It's just more of a comment than a question, but to say, you've talked about a better computer, absolutely needed, talked about a better doctor, absolutely needed, but perhaps to get from 15 to 100, we need a better patient. The societal aspects and the acceptance aspect of your own responsibility are key.
I think there's huge opportunities. In fact, the market activation energy to get to us rather than the healthcare system may be lower. Colin.
I just want to make a lowbrow comment.
Could you identify yourself?
Colin Stoltz, MIT. The question about whether one needs a better doctor or a better computer, I think, is ill-posed. We need better health care. And I think the analogy that's instructive here is systems biology. So, in systems biology, whether one thinks that's a good enterprise or not is a separate discussion. But the principle is that you have cells or other sorts of biological organisms that are made of complex, disparate parts, and you need important and new algorithms to try to understand how all of these parts work together to have the organism do whatever it needs to do. And so you need sort of a healthcare cyborg, let's say, or some sort of integration of the two that's going to provide, that can integrate genomic data, patient history, and all of this stuff to come up with better risk stratifiers. Risk stratification is an objective function, to be able to say, and I think if one approaches it from that point of view, I think that would be helpful.
Bill, do you have anything to say about the systems approach to?
I totally agree with what he said. I actually believe that the modeling challenges that we have not, as far as I know, even scratched the surface with system biology are in fact the same. So I think we'll discover it's a common problem. So I simply agree.
And unfortunately, part of the problem is we actually don't know what we even know. In other words, there are things happening to our patients today that we're fully unaware of. Please identify yourself.
Julian Goldman, Mass General Hospital and Partners Healthcare. I wanted to thank you for offering to make me a better doctor. And I felt like there was an idea that was close to being touched on in the different presentations, but wasn't quite articulated, so I wanted to ask this question. We talked about looking at patient populations and statistical methods for decision support and other methods of aggregating information and so forth. But one of the challenges that we have in treating patients is that clinicians have different approaches to treat problems, and we have no very effective way of knowledge sharing. We have a consultation method, and there are emerging approaches to that which are highly inefficient. The social networking approach, it's still a matter of trying to find someone at the right time to consult and answer a question. And yet, we don't seem to have a way to look at the entire context of a patient environment, and as a clinician would do, interpret labs and other information. And, as we see it all the time, someone with a certain insight in a certain institution because they learned from someone in some setting or maybe in a battlefield or somewhere else has an insight that other people don't have, and it can be a life-saving insight. And I'm struggling to understand how we ever will get to the point where we, as a healthcare delivering part of society, can become smarter or become better doctors. And yet I felt that it was implied in a few of the presentations, but not explicitly stated.
So Latanya, and then Bill. How would you think about answering, I think there's two questions buried in there. One is, how do we become more situationally aware of the entirety of the patient context, and how do we become more aware of expertise that might pertain to the patient?
In real time.
Fine.
There is a vision, there's a vision or a hope, and it's getting some momentum, that the part of the problem is that there's not enough capture of information from the patient. So one answer, a partial answer, is that a belief that systems who do more of the monitoring in the home provide more lifestyle information, more observations about individuals, and to what extent could they also feed into the provider to help make decisions. And as soon as and there have been several companies who sort of have been big, large companies who've been kicking that around, and some of them have started to do market analysis and things like that. And if that were to happen, that's kind of an interesting model, because then what would happen is it would have a traumatic effect on the patient-provider, the patient-physician encounter. Because now there's so much we don't know about the progression of a disease, or even medical compliance to medications that you're giving, that have to do with the person's lifestyle, has to do with other decisions about care that aren't captured, that are sort of outside of the information that you're capturing in the clinical environment. And so that might offer some insight into it. So that answers probably the first question, but I'll let Bill deal with the second one.
I really think it gets at this idea of a systems approach to care. Right now, we operate in a non-system, and as individuals, we mediate our use of the evidence. Our practice is evidence-based, but it's individual expertise mediated. The population at large know that because the goal is to get to the best doctor. Think about that for a second. That means two doctors are not practicing in the same way. And in a systems approach, what you actually have to do is sit down and look at all of the sources of evidence and then say, what is the variation in the evidence? Which applies to the resources in this environment, in the patient mix in this environment? And then what's the process that lets me systematically apply that so that I consistently do it? And then how do I mine data so that I can tell in real time whether the patient is where they're supposed to be or not? And then let the human make choices, but within control limits. You've then taken all the noise out of the system, the unwanted variability. You're then left with intentional variability, at which point the feedback from outcomes becomes a much stronger system. We at Vanderbilt, we've worked through this over the last 2.5 years in the area of ventilator management. It's taken 2.5 years. But at the end of that time, if you're on a ventilator at Vanderbilt in any of our intensive care units, for more than 96 hours, you have lower length of stay, lower cost, lower mortality than any other academic center in the country. But it's been totally focused on that one problem for 2.5 years. How we get to where we do that for everything we do is the subject of this research.
Thank you. The gentleman in front of the mic, please identify yourself.
Hi, Abdul Sheikh from the National Cancer Institute. This is primarily directed to Bill, and really kudos on an excellent report that you and your colleagues did back in January. You alluded to this inherent tension between the notion of data standardization versus data interoperability, and I think it touches upon implications related to this idea of systems thinking, and it's challenged by the richness and variability in different kinds of health-related data, be it from the genomic, proteomic level up to behavioral and social and population health data. Can you speak a little bit more about how we can balance this tension between data standardization versus interoperability and portability?
A good point, and again, it plays back to Latanya's point about how do you get the and in between between the two. Anybody that has taken a picture with a high megapixel camera and take it, the thing, my hobby right now, wildflowers, and set that picture beside a few words that in the biological terminology describe that wildflower, you will discover that although it will get you to the right species, it will not in fact get you to the fine variation in the subspecies. So our standard words are lossy compression. And if we capture our raw observations with lossy compression, we lose signal. So the trick is to capture the raw signal. I frankly like to see my patients' digital photography of what's going on in their life. That's a much I can get in a person I've known for some time, I get a much better picture of what's going on than I get if they tell me. That's an example of raw signal. You then want to have standard terminology, concept maps that you say, okay, this is what I think is going on here, and you want to annotate that record of the raw signal with the standard terminology. And that standard terminology can in fact interoperate, but whenever anybody questions something, they can then go back and look at the raw signal. And if we make that a human-machine combination, then as the concept map changes, you can actually have the algorithms go back and reprocess the raw signal and give you a suggested update of your annotation. So I think the success comes in never throwing away rich buckets of raw signal and then treat the annotation as a separate layer, less specific, that sits up on top of it. That can then be interoperable. So it becomes an anding instead of saying one or the other.
Great. Bob, please identify yourself.
Bob Greenis. Right now, as we're having this largely technologically oriented discussion, there's a lot of discussion by our representatives in Congress about our healthcare system. And while health IT is part of that discussion, clearly financing and incentives for healthcare are really top of the list. And there was a report the National Academy of Engineering and IOM jointly did, what was it, 5-7 years ago, on re-engineering our healthcare system. And a large part of that was really tied to the financing and incentive structure of the system. So one question I think we need to ask ourselves as we go through this discussion about how technology can help is how we can kind of make the right thing to do, the easy thing to do, so that the financial portions of this healthcare system can align better. I think right now technology is not usually the driver, and we need to figure out a way to align and not ignore that whole part of the activity.
Latanya, you had set up at least a straw person about the billing infrastructure as potentially a vehicle. Perhaps you'd comment.
Yeah, actually, so let me explain why the current happening at ONC is critical to this discussion. So the way the stimulus bill worked is it gave $19 billion to ONC for the purpose of incentivizing this structure to happen. In order for the structure to happen, it goes back to very much what the conversation has been about, the patient-provider encounter, i.e., let's build a new computer system for the provider the provider will buy the new system, and the government will reimburse them for the purchase of that new system. So that's how the system was working, and the first rollouts are in 2011, 2013, and 2015. So the question is, what should we ask that provider system to do? What's the list of uses and applications that are the ones that should be reimbursed, that if the system adheres to them, will reimburse them? And so those are called meaningful uses in the terminology of the policy. The paper that we'll provide you with later actually lists them. It has a table that lists the ones, especially the ones that are well-defined, are actually listed. And they primarily came from primary care physicians, and you'll see that they're directly related to the care of the physician. But many of them require a kind of interoperability across systems to actually be fulfilled. So that might be a good point to look at to see what kind of uses have people already said that these new provider systems need to have, and cross that with the discussion that's happening here as to ultimately what really should be going into those provider systems.
I just want to point out, and I can say this since I'm not a member of the government, there will be some level of success in that current investment, but there'll be also some less success in that investment. And I think that there's an opportunity for all of you here in the room to think about the following, which is, it has been the case that if the technology has actually delivered something truly useful both to the patient and provider, people will pay for it, and they'll pay for it a lot happily. Getting an MRI instead of having a surgeon go in with a knife into your brain, people pay for that technology, and that is a combination of computing and other technologies. And we have many, many such examples. And so I urge you to not say, well, that ship has left the harbor. There are going to be many opportunities for you to contribute, develop technologies that will be seen as useful, enabling, and I think well-funded.
Well, let me just add on to that. Two things. One is, one of the things that really prompted a lot of me pushing back on ONC and pushing back on this gap on the infrastructure was actually the earlier work that you guys had done about the emergency room. I mean, why can't I get this? And showing how if I use the billing system, I could get this. There's lightweight information that we can put into the 837 transactions and so forth, that we can actually get it into a repository and get it out. So that was very helpful. And I think you're right to say, but that's only the beginning of it, because what that means is now we have a mechanism that can deliver instant information. Show me a good use, show me a good algorithm, and we'll know what better to capture, how to capture it, and where to put it, and not only necessarily through that mechanism, but through the exchange. So you shouldn't think that the idea that the ship has left the harbor is absolutely right. Don't think about that. The point of the conversation is to say the landscape is changing so that there will be this opportunity for more data exchange, which will give us an opportunity to have richer algorithms. And the other thing I wanted to say is the other thing that's been driving a lot of my work with ONC has been economic incentive for continuation. So I've been very focused on how do we set up things so that if a new algorithm comes out, it doesn't get locked in a silo of one manufacturer. How do we make sure that we continue an economic mechanism for the data to flow and for new innovation to happen?
Before we go further, I want to look at the non-jet-lagged co-chair and ask her, can we entertain one or two more questions, or should we put a close to it?
What we're doing is we're cutting into the break, and if that's okay with everybody, it's fine with me.
So she just ably put it back onto me. So let's say two brief questions, and then we're done. Sir.
Mark Bronstein, Georgia Tech. Actually, I want to tell a story rather than ask a question.
Go for it.
I was looking at the session title and noticed it included the word patients in it, and I thought I'd tell a story about health IT and patients. To understand the story, you need to understand I came to Georgia Tech after years running health IT companies, and my last company focused on home health care. We developed an EMR for home health care, which many hospitals around the country used. And in '98, we started thinking about what we could do for patients. So we developed an early home telehealth system. The details are interesting, but it was a very interactive little device that talked to patients. And we installed it. One of the early installs was in a major hospital system in northern New Jersey, and they started reporting back to us that they were seeing a dramatic reduction in rehospitalizations and ER visits by the patients using this thing. So I flew up to New Jersey, and I'm a physician by training, and went around and visited some of these patients because I was very interested in which of the many technical aspects of this system that we had worked so hard on really were making the difference. It was completely integrated with EMR, which was unique, so it knew a lot about each patient. Of course, the patients were all elderly women living alone with congestive heart failure, and I would go visit them, and it was a big deal. I mean, you know, the women would dress up, and they'd have tea and all this sort of stuff, and you really wanted to stay longer than you could because they enjoyed the visit. But the point of the story is what they all told me about which of the many capabilities and technological aspects of this system we'd spent really 5 or 6 years developing were making the difference in terms of keeping them out of the hospital. It was because they didn't feel alone anymore. Not only did this device talk to them, they would talk to it. Of course, it didn't have voice recognition, but they knew there was a nurse on the other end paying attention to what was going on with them. And that meant the difference in the middle of the night when they got up not feeling well as to whether they played with the device and went back to bed or whether they went to the emergency room and sometimes ended up in the hospital. So this is using Latanya's flashlight. There are many pieces to this monster in the dark room, and I hope as we think about this agenda, we think that broadly.
Thank you. Last.
Jim Harrison, University of Virginia. This is just a comment too, so hopefully it won't take too much time. One of the topics I think that's implicit in the discussion this morning, and I just wanted to highlight this, was the need for systems that we use to do a better job of capturing and categorizing medical error and medical process problems. And I just want to illustrate that. I'm not really talking about mistakes people make, but as a clinical laboratory pathologist, I know of at least half a dozen instances over the past 10 years when formulations of test kit components and so forth from vendors have actually changed results that those tests produce in clinically significant ways that weren't entirely obvious when those kits were implemented and that we find out about only later. And for example, when BD changes the formulation of surfactant on the walls of tubes that blood is drawn into, and that affects 3 or 4 tests, we shouldn't be hearing about that weeks or months later by a chance meeting in the hall with a clinician who tells me, you know, this test just isn't giving me the same results in some patients as what I'm used to seeing. Is there some kind of problem that you guys are having in the lab? We shouldn't be hearing about that then. We should hear about it almost immediately through feedback that the system supports. Now, we're in the process of implementing a new electronic medical record system at Virginia, and we would love for every piece of clinical data in that system to have a way as part of the routine workflow for somebody to pop up a window and type a comment and send it and have that go back to the service that generated that piece of data. Now, for us, we'd like that to come back to the lab, and we'd like to be able to capture and categorize those comments and use them to improve laboratory services. But we don't think that that's specific to the lab. We think that that's a useful capability for all services that generate information that goes into the medical record that supports clinical decisions. So I think that's an important issue, and I just wanted to highlight it.
So I think this relates to an earlier comment made by someone that we have to figure out how to share the right data and the right knowledge at the right time, and it's highly not obvious in how to do so. I don't want to give you just a final defining anecdote, which brings to mind when you eat from the tree of knowledge, the first thing you realize is you're naked. And so here's an x-axis represents 1997 to 2007 in Boston, the Partners Healthcare System. On the y-axis is the rate of a important syndrome. And what we see is this huge rise of 18% of this syndrome. What is that syndrome? It's heart attacks. So there was this huge rise in heart attacks, of 18% increase in heart attacks. That happened in Boston. Point number 1, no one knew about it. It was there in our databases. Point number 2, if you did some very simple analyses, it was very clear that the bookends of that were Vioxx, and that if you looked case and control on the individual patients with or without the heart attacks, there was a huge odds ratio in Vioxx. This is something that was happening under our very nose. John Glasser, who's also at ONC, is my co-PI on I2B2, which is our National Center for Biomedical Computing. And rather than stuffing me in the deepest hole he could find when I reported on this, he said, we need to create a way of actually managing this. But I'm just providing an illustration of how much ignorance there is in our system, how much opportunity there is to actually find useful things, just as we're describing right now about the surfactant in the tubes. The real question is, who's going to integrate that knowledge? How is it going to be integrated? I don't believe we have actually enough human brains thinking about this all the time necessarily currently. And maybe there's a way to distribute that intelligence, maybe there's a way to automate it in part, but there are huge opportunities just as raised by the anecdote. With that, I want to be very, very mindful of the fact that you need to get your glucose levels back up. Thank you very much to our presenters.
And Susan, when are we coming back together?